It's almost, in fact it is, 6:30. I mean, we like to run everything in the RSN these days with military efficiency and precision, and you're all very welcome this evening, so thank you so much for coming. And I think we have some people online, I believe, so hello everybody online. These days it's much easier to stay at home, isn't it, and watch these things at home and have a glass of wine and so on your sofa. But if you're here, this is where the action is, because we've got the interaction between us and the speaker and so on. So I'm just going to read this out because I'll make a mistake if I try and remember it. Professor Sir John Cunningham was born in 1949 and educated in Magdalen College School, Oxford, Trinity Hall, Cambridge, which is the place that I prefer, of course, and then he went back to St John's College, Oxford, and also trained in Washington University School of Medicine, St Louis. He became a professor in urology at UCL Medical School and the Royal Free Hospital, where he largely works, and holds appointments at the London Clinic and King Edward VII Hospital. He was head of the medical household to Queen Elizabeth II, between 2005 and 2014, and occupied position of physician to the Queen. That is very impressive. On stepping down, he was knighted by Queen Elizabeth II as KCVO. So John, you're going to give us a talk about the kidney, about the issues around the kidney and how dangerous it is to have kidney problems, and then I'm going to ask at the end my dear friend here, Ted, to come and say a few words of thanks. There will be questions from the audience, and also if I can get the iPad working, we have some questions online as well. Welcome everybody. Sir John, you're on. That rhymes. There you go.
Well, thank you very much, Roger, for the introduction. A little bit over the top, but we're talking about Professor Kirby here, so no surprises. But it is seriously a great privilege and honour to find myself addressing a crowd like this, and I think a lot more people out there. I don't know how many out there. When Roger first asked me to deliver this lecture, I said yes pretty quickly. Didn't really give it as much thought as I should have done. Now this is typical Kirby. He catches you by sneaking in below the radar when he wants you to do something. He's very good at it. And he caught me out because I then, too late, read a little about the Jephcott Lecture. And I looked at the list of previous speakers, and I immediately wished I'd said no, because this is quite a daunting series of precedents for me. The bar's very high. So we'll do our best, but no promises. The topic I've chosen is one that is a mixture of science, clinical, and some more general comments. So I hope there's something of interest for a reasonably broad spectrum of people here. I've called it Crosstalk between the kidney and the heart, a dangerous conversation, and the reason for that is that these two organs, which are both critically important, of course, to us in all the ways that we're aware of, do have a conversation between themselves all the time, and if things go wrong with one, there is inevitably a major knock-on effect for the other. And because of the critical importance of these organs, that means trouble. So we'll kick off and see how we get on. Now, those of you that have any interest at all in rugby will recognise this site here. The large man with the ball is a chap called Jonah Lomu. He was an all-black rugby player, probably the most famous all-black ever, I suspect. An enormous man, ran the 100 metres in under 10 seconds and was unstoppable. And you can see that the forlorn attempt to bring this man down as he's heading for the try line being made by a gallant Englishman by name Rob Andrew, who was then playing for England and doomed to fail. Lomu was too big, too fast, too strong. He cut swathes through all the opposition for a number of years. So he was a superstar rugby player. Born in 75, and between age 19 and 27, he was an all-black playing for New Zealand. He was the youngest person ever to represent New Zealand. He had 63 caps and 37 tries. So far, so good. But when he was 20, so early in his career, he developed nephrotic syndrome. And a biopsy was done and revealed a condition called focal and segmental glomerulosclerosis. Now, the nephrologists around will recognize that condition as one of the causes of glomerulonephritis. It's a nasty one to have because it tends to progress to renal failure, excuse me, and the treatment, the only treatment that is effective, is pretty nasty, requires heroic doses of steroids for quite a long time with lots of the expected side effects. So this is not a good condition to get. He carried on playing rugby on steroids. Interesting to contemplate how good he might have been if he hadn't been on steroids all that time. These are the sort of steroids that would tend to slow you down rather than speed you up, by the way. But he eventually progressed to end-stage renal disease, had to start dialysis. He then got a kidney transplant, but as is wont with this particular condition, which is one of the reasons it's such a nasty one, he got recurrent disease in his allograft, in his transplant. That eventually failed, back on dialysis. And of course his rugby career gradually petered out at this time. So that's all pretty clear-cut, somewhat sad story, but much sadder when this happened. So he dropped dead at the age of 40, completely out of the blue, and this was basically a sudden cardiac death, almost certainly a dysrhythmia. So there we are, short and sweet and very sad. Now, a very prescient comment that's pertinent to what we're talking about here was made by Thomas Sydenham a long time ago, in the 17th century. A man is as old as his arteries. And I think there's so much truth in this that it's one of those mantras that's worth repeating to oneself from time to time as we pursue our activities in clinical medicine, and indeed way beyond as well. Now, chronic kidney disease is important in that, to drill down or cut to the chase, it creates an enormous divergence between biological age and chronological age. Biological age runs ahead of the curve, as it were, in relation to chronological age. So we're all aging, and a whole load of things are happening as an inevitable part of aging. These are all speeded up greatly in the presence of chronic kidney disease. So it's a disease of rapid aging, not good in that sense. Now, how big a problem it is? Well, globally, it's a huge problem. If you look over on the left-hand side of this, these are let me see if I can make this thing a little bit more obvious. I think that's the one I wanted it. Pen, laser pointer, let's try that. Yeah, that's the one. So we've got not far short of 1 billion people with chronic kidney disease at one level or another globally. There's about 1 in 10 of the global population. The demographics are as follows. Individuals with diabetes are overrepresented. Women are overrepresented. Individuals with hypertension are overrepresented. The elderly are overrepresented. And a number of racial minorities are overrepresented as well. So there's some big socio-political and socio-economic implications here with those numbers. If we look at the trend for the future and predictions for the future, in 2013, chronic kidney disease was estimated as being the 19th biggest killer in the world. Look at these increases. 2016, the 13th, 2017, the 12th, and predicted for 2040, the 5th biggest killer in the world. This is a massive rise. Now, why is this happening? Well, there are two things going on here. One is in the West, obesity and diabetes are probably the main drivers there. In the developing world, it's the gradual shift away from the traditional developing world diseases, mainly infections, malnutrition, which are tending to kill people quite quickly and when they were youngish, towards the diseases of the West, namely obesity, diabetes, hypertension. So there's a massive shift going on across essentially the whole of Africa, Southeast Asia, India, South America, etc. And that's probably the main driver to these rather frightening changes. Now, in terms of the causation of this epidemic of chronic kidney disease, these data from the USA, fairly recent, and if we look at diabetes and hypertension, they account between them for at least 2/3 of the total. Now, it's important to note that those two conditions obviously have their own major cardiovascular implications, quite independent of the kidneys. So you've got the two big drivers to kidney disease here that are also independently driving cardiovascular disease. And if there's a tendency of the kidneys to drive cardiovascular disease, there's a double whammy on that basis. So not good. Now, the world as viewed by the typical cardiologist looks something like this. And certainly the nephrologist as viewed by the typical cardiologist probably looks something like that. And they're in a big silo, we're in a little silo, would have been the general perception in that specialty and many others 20 years ago, even 15 years ago, certainly 20 years ago. But it's not just like that, because there's another way of looking at it. and we've tended to look at it in that way, and that makes a lot more sense to us from the renal side. But the serious point I would make here is that because we've tended to be in our respective silos, and there's in some ways an increasing divergence into those silos in medicine in general. And this, I think, is a real problem with medicine. I'm just making a philosophical point about how medicine's done now. We're much, much more stuck in silos than we used to be. But this particular pairing, as it were, is potentially quite destructive, but there's been a major coming together, I'm happy to report, over the past 10 to 20 years. So things are much better than they were in that respect. Now, this brings me on to talking about scenarios that the terminology is probably familiar to many of you, so-called cardiorenal syndromes. Now, simply put, this basically means disorders of the heart and kidneys, whereby an acute or chronic dysfunction of one or the other induces acute or chronic function in the alternative organ. So the heart drives kidney disease, the kidney drives cardiac disease. So this two-way traffic is going on there. And if we just subdivide those into a little more detail, we can look at cardiorenal syndromes, type 1 and 2, and renocardiac syndromes, type 3 and 4. And essentially, the cardiorenal ones fall into acute and chronic, and the renocardiac ones also fall into acute and chronic. And if we look at this typical causation here, the acute cardiorenal one would be acute heart failure, for example, and the kidneys take a knock when that happens. The chronic cardiorenal one would be chronic heart failure, and the kidneys take a knock when in that scenario as well. Going the other way around, acute renal failure, acute kidney injury will generate acute problems in the heart and circulation. Chronic kidney disease, CKD, likewise will generate chronic cardiac disturbances. I'm not going to talk about this lot down here at the moment. So that's the sort of scenario that exists. Now, I thought it was just worth just very quickly reminding you what CKD is, because it's an expression that is thrown around like confetti, very casually used, in my opinion, and often used in a way that indicates that the person using it doesn't know what it is, and very often the person listening to them doesn't know what it is either. So here we are. This is the criteria. These are criteria for diagnosing chronic kidney disease. So any one of these here, now these are manifestations of kidney damage. So that can be proteinuria, it can be electrolyte disturbances, it can be histological abnormalities or structural abnormalities when the kidney looks funny on a scan, or a history of kidney failure with transplantation. So you need one of those, or you need decreased GFR below 60 for a period of at least 3 months in both cases. So it's quite simple. One of this lot, or decreased GFR. Will tick the box for chronic kidney disease. And the duration of greater than 3 months implies irreversibility, or at best partial reversibility. So that would tell us, therefore, that there's some limitations on what this really means. So in many cases, it may be just a syndrome or even a scenario, call it what you will, because you don't actually have a pathological diagnosis unless you've done a biopsy or you've seen what the kidney looks like in some other way, or you've seen obstruction, for example, on imaging. So it doesn't necessarily yield a pathological diagnosis, which is really what we ought to be striving for as much as we can in medicine. So I think it's often overinterpreted in that sense, and you frequently see patients coming out of hospitals with a diagnosis CKD, and no further elaboration on what the CKD was all about, what was causing it, etc. Pretty sloppy, in my opinion, unfortunate. Now, if we look at the implications for the patient of having CKD at various stages, we see this sort of picture. Now we've got a family of curves here, and we've got good renal function on the right down here, falling down to near dialysis on the left here. And if we look at patients who are essentially normal in respect of protein excretion, that's this lot here, you see that the kidney function can diminish to about 75, something like that, with little change in the risk of ending up with end-stage renal disease and ending up on dialysis. Once you get below 75, it really takes off though. So you don't need to lose much kidney function before you have a massively increased risk of ending up on dialysis. And note, this is not a linear scale here either. So with a GFR of, say, 45 or so, you've already got a 16 to 20-fold increase in future risk. So that's a massive accelerator, as you can see. Now, if you have proteinuria as well, either low-grade proteinuria in green or heavier proteinuria in red, the same relationship exists, but it's all reset at a higher level. So you've got a family of curves here, and if you've got proteinuria, even with good kidney function, you've got a substantially increased risk of ending up on dialysis. So proteinuria is bad, and low GFR is bad. Both together, very bad, is the bottom line here. Now, you don't need to lose much renal function to start increasing mortality risk either. So we were talking, that previous graph was talking about the risk of ending up on dialysis. This is showing the risk of dying. And again, we've got good renal function out on the right, bad renal function on the left, and you can see that as renal function diminishes, when you get down to about 70 or 80 or so, the risk starts taking off, and it rises very steeply indeed, such that when you are near dialysis, you have, this is the median line here, you have an 8 to 10-fold increase in mortality risk. So this is not just kidney disease, this is risk of dying. So again, it's a very big marker of future risk of death. Most people would think, well, GFR 50 or so, something like that. Patient feels completely normal, getting around, etc. They're told that it's only minor loss of kidney function, but this is what it's doing to their future lifespan. It's having a big impact on what may happen. Now again, just to emphasize that point further, these data a long time ago, look at that, 1998, but nothing's really changed, or nothing's changed radically since then. And this remains a pretty good study in my view. Very large numbers of patients, tens of thousands here. And looking at the age-defined relationship with mortality. Now if we take the normal population, women and men, we see, as expected, an incredibly low mortality risk when you're a young adult, down here. Rising steadily as you get old, no surprises there. If we look at the same thing in patients on dialysis, we see that even when you're young, there's an incredibly increased mortality risk. It's in the order of 50 to 100-fold increase relative risk here. And it's relatively flat thereafter. So the young are in nearly as much danger as the old, in fact. There's not a huge increase as you get older. There is an increase. And there's still, if you're 80 or so, it's better not to be a dialysis patient than to be a dialysis patient. But the difference is nothing like as much in relative terms as when you're a youngster. So this is when you really are looking down the gun barrel and potentially losing a lot of life years. And if one does some calculations around that, we find that a dialysis patient aged 25 to 34 has the life expectancy of a normal 85-year-old, a healthy 85-year-old, which is hard to believe, but those are the figures. This is really stark. And that makes dialysis much more dangerous than most cancers. There are not many cancers that are more dangerous than that. It's not a fact that is widely perceived out and about, probably not that widely perceived in the medical profession, certainly not amongst the general public, who have little idea of the danger they're in when they've got significant loss of kidney function. Most uremics who are going to die of cardiovascular disease of one kind or another. There's more cancer in that group, certainly, but still more will die of cardiovascular disease. And interestingly, the patient who's got moderate loss of renal function and progressing towards dialysis is more likely to die on the way than to get to dialysis. Such is the high risk of the cardiovascular disease on the way. So this is not a very encouraging position. If you know these facts and you are a patient with a progressive kidney disease, this is not something that's going to help you to sleep at night. CKD has bad effects on virtually any kind of cardiovascular disease you care to think of. So we're looking here at the green bars depicting the percentage of patients with cardiovascular disease, and those without kidney disease are depicted in yellow. And so any cardiovascular disease, coronary artery disease, acute MI, heart failure, valvular heart disease, strokes, peripheral artery, you name it, they all have a relative increase in risk of about 2 to 4-fold going across the whole spectrum of cardiovascular disease. So it doesn't really matter which facet of cardiovascular disease you look at, they're all getting worse in this sort of scenario. Now, why is this? Well, one of the things that's going wrong in quite a dramatic way in these patients is they calcify their vasculature in a big way. Now, we all know that vascular calcification is something that happens in many people as they get older. So this is part of the aging process. We also know that it's not a good prognostic feature to have extensive arterial calcification. Now, if we look here then at the coronary calcium scores, again, data from a good while ago, but nothing's changed here. So the current data are virtually the same as this. And we look at coronary calcium scores in patients with no coronary disease, with coronary disease, so those two groups without kidney disease, and then those on dialysis. We see the no coronary disease and no kidney disease, basically none when you're young, virtually none, and then a little bit as you get older, coronary calcium score. If you've got documented coronary artery disease, it starts rising with age progressively, not surprising. Kidney disease, it takes off much earlier and goes much, much higher still. So these kidney patients are calcifying their vasculature a lot quicker than the general public. Calcification's very different from the type seen by the cardiologists the whole time when they're stenting and doing angioplasties, etc. This is what the cardiologists are generally dealing with in the coronary circulation. Intimal disease causing atheromatous plaque, occlusive lesions, which may be chronically occlusive or acutely occlusive. So that's the sort of standard scenario we think of, atherosclerosis. Here's the normal. The patients that I see have got a slightly different process going on. They may have that, admittedly, but they also have this thickening of the media and medial calcification. So it's a rather different scenario, and these very high calcium scores we see in the renal patients is mainly reflecting this medial calcification. Of course, the imaging of that kind struggles to differentiate between the two different kinds of calcification, but we know from pathological studies that a large amount of it is medial. And that translates to bad outcomes. So if you look at the quintiles of arterial calcification, not actually coronary, this is in the carotid, aorta, iliofemoral, etc., you can see that the probability of survival is heavily determined by whether you've got a lot of calcification. So you do very well if you haven't got calcification, and very badly if you've got a lot of calcification. So again, a rank order. The more severe the calcification, the worse you do. These are patients on dialysis. Now, in parallel with that is a rank order of pulse wave velocity. I'll say a bit more about that. I know there's probably some cardiologists around here, and so I've got to watch my P's and Q's carefully here. But pulse wave velocity means just that, of course. It means the speed at which the pulse wave is propagated through the arterial circulation. And there are many things that determine that, but the biggest one of all is the compliance of the arterial circulation, how elastic it is. Now, if it's not very elastic and quite stiff, as it tends to be if it's calcified, the pulse wave velocity is high, and if it's nice and elastic and flexible, it tends to be low. And the lower your pulse wave velocity, the better you do in terms of survival. So here's those who've got good quality, distensible arteries, low pulse wave velocity. Here are the ones who've got aging arteries, as you get with hemodialysis, and they do much, much worse. So this is pretty well superimposable on the calcium score figure I showed you on the previous slide. Now you may ask, well, why is it that pulse wave velocity matters? And I'll try and talk you through this. Essentially, we have here on the left-hand side the normal scenario, and on the right-hand side the scenario when we've got very stiff arteries that may or may not be calcified. So normally what's happening is you have the systole, rapid ejection of blood from the heart, and then as the pressure drops, the rate of ejection diminishes and the pressure diminishes, and there is a pulse wave that transmits forward into the aorta and the major proximal vessels, divisions from there. But those big vessels essentially perform two functions. They have a cushioning or buffering, dampening effect, and they have a conduit effect. The conduit effect clearly is just transmission of blood. The cushioning effect is elastic. So each time the heart contracts, energy is stored in the elastic aorta and can be released when that elasticity ejects the blood from the aorta. And that's what happens during diastole. So in diastole, cardiac output diminishes to virtually zero, well, to zero, and the diastolic pressure is largely maintained by that recoil in the elasticity of the great vessels. And it stops diastolic pressure going too low, and also attenuates the rise in systolic. So these people tend to have a nice narrow pulse pressure. Conversely, the patient with stiff vessels does this. There's very little cushioning effect, so systolic pressure tends to be high, and then diastolic pressure crashes because the wave actually ricochets back from the hardened circulation too soon. There's very little cushioning effect, and effectively collides with the end of systole. And by doing that, increases the ventricular afterload a lot, which again the ventricle does not like at all. So that these phenomena are very bad for the left ventricle. Unsurprisingly, therefore, you see a lot of left ventricular hypertrophy when kidney disease, in patients with kidney disease. And if we look at this, normal or good renal function, slightly impaired, down to dialysis, again, we can see an increasing probability of left ventricular hypertrophy. The lower the GFR, the higher the prevalence of LVH. And again, this is not a good thing. Hearts in this situation are not built to last. And if we try and just walk through quickly what this leads to in the heart and the circulation. We'll start on the left-hand side here. So the uremic heart is subject to both metabolic and mechanical stresses. This leads to fibrosis in the myocardium, dilatation of the left ventricle if it's going to fail. You may get a congestive cardiomyopathy picture. Left ventricular hypertrophy, which leads to diastolic dysfunction because the ventricle is stiff. So all this is not good at all. Big hypertrophied left ventricles tend to be unstable and arrhythmogenic, and this is probably the reason why these patients have such a high incidence of sudden death, sudden cardiac death, rather like poor Jonah Lomu, for example. And I happen to know that he had serious hypertension for much of his time with renal failure, and so I'm sure this is what was going on. He probably had plenty of this going on in his heart, poor chap. Then we've got calcification and atherosclerosis in the vessels as well to contend with. So that's the cardiac consequence. If we look at the blood vessel, what we have here, we can still get intimal atherosclerosis just like anybody else can. But we're getting arterial wall thickening and stiffening and vascular calcification at a much accelerated rate compared with anybody else. Plaque rupture and thrombosis, like in any other scenario, can cause acute occlusion and in myocardial infarction if it's in the coronaries. Now, what does this do in terms of the patient? Well, if we look at atherosclerotic cardiovascular events, so these are the occlusive ones, we see a progressive rise as the GFR falls. So this is no CKD, and this is end stage renal disease. And there's a progressive rise in the frequency of atherosclerotic cardiovascular events. This is coronary artery disease, stroke, peripheral arterial disease. But it does tend to level out about halfway down the line. And the increase is not linear beyond about CKD stage 2 to 3 in old language. If, on the other hand, you look at non-atherosclerotic events related to the cardiovascular system, here we're talking about left ventricular hypertrophy, arrhythmias, sudden death, calcification, all these things here. These continue to rise in a linear fashion and get worse and worse right to the bitter end, reflecting the ongoing, largely linear increase in risk as GFR falls. So we've got these two different processes here, which frequently coexist, of course. All the complications that exist on this slide have a higher mortality in patients with CKD than they would in the normal population. There are a range of reasons for that, which I'm not going to go into, but when you're more likely to get these complications and they're more likely to be fatal. I'm not going to go into what's happening at the cellular level for long at all. I think it's the only slide I've got that does it, maybe one other. So if we look at the vascular wall, the wall of an artery, the media is largely made up of vascular smooth muscle cells, which are obviously contractile. The renal patient exhibits a transdifferentiation of these cells towards a phenotype that is more like bone cells, like osteoblasts. And what do osteoblasts do? Well, they make bone-related proteins and they calcify. They make bone, basically. And so these cells get up to a lot of mischief in the media of the arterial wall. You do not want this sort of process going on in the media of your arteries. And this process is accelerated by various things that are highly prevalent in kidney disease, like a high calcium phosphate product, high phosphate, for example. There are various counters to that calcification. Fetuin is one that's quite well known, osteoprogesterone and matrix-R protein. So it's an opposing set of influences determining the extent to which you are moving in that direction of calcifying your blood vessels. But the point I'm making, it's largely a cell-mediated process. It's not just physicochemical due to a high calcium phosphate product. Right. Next, can we mitigate the effects of kidney disease on the cardiovascular system? Well, I'm going to talk about three. I'm going to talk about lipids, blood pressure, and I'm going to then talk about these drugs, the SGLT2 inhibitors. I'm not going to talk about GLP-1 analogues, which are new and exciting in their own right, I'm not going to talk about bone and mineral metabolism, although I spent a few decades of my life immersed in that. And I'm not going to talk about inflammation either, although that's still a big factor here. And really, we haven't time to do all these things. So let's talk about lipids briefly. Now, we all know that cholesterol is a very good predictor of cardiovascular disease in the normal population. And furthermore, we know that if you treat it, you can improve outcomes in a very predictable way. So that's all cut and dried, basically. So if we look here at the hazard ratio of, this is the hazard ratio of cardiovascular events in patients related to their GFR. So here's good kidney function, GFR of 90, 60, 45, 30, 15. So kidney function getting worse and worse as we go down here. And we're looking at the effect of the LDL cholesterol concentration on the risk of cardiovascular events. Now here are the normals. This is what we hope people like us are all about, where there's a linear relationship between LDL cholesterol and the risk you face from it. And that's quite a good relationship. Huge number of studies have confirmed that. So that's pretty cut and dried. I'm not going to talk about the U shape here at the moment. So this is the part we're interested in. As the GFR goes down, that relationship weakens progressively. So the slope here is flatter, flatter still, flatter still. And the level of significance is getting less and less as well, to the point where when your GFR is down to 15, it's no longer significant. So you might predict from that if you take patients who've got a low level of kidney function down here, and you do something to bring their cholesterol down, give them a statin, it may well not work as well in these patients as it does in the normal patients with normal kidney function. That will be your prediction. And indeed, that turns out to be the case. So here in a meta-analysis, summarize the data from 28 randomized controlled trials, looking at individual participants in those studies. So this is quite a good meta-analysis, I think. Obviously, we all know that meta-analyses are not the perfect solution in many cases, but this is, I think, quite a good one. So if we look here, this is a forest plot here, looking at the potential benefit of cholesterol lowering. So if the median points here are to the left of this line, that supports the notion that treating cholesterol is good, and if they are not to the left of the line, it suggests that it's either no good or even bad if it's right over to the right here. So good levels of renal function, greater than 60 ml per min GFR, there's no doubt there's a clear benefit, as we would have predicted from the previous graph showing the association. But as the GFR comes down through the stages, you can see that the clarity of that benefit diminishes progressively, to the point where it's no longer quite significant when the eGFR is down to 30, and it's flagrantly insignificant when you're on dialysis. So rather, as you would predict from the previous slide showing that loss of a convincing relationship, it turns out to be the case when you actually treat the cholesterol with a statin. Bottom line here is that the worse your kidney function, the less useful a statin is likely to be, which is just another problem for the kidney patient to face. They've got all these risk factors, and this one here, which is a big one, of course, cholesterol, is refractory to treatment when you are on dialysis. What about blood pressure? Well, blood pressure is a huge issue in renal disease, and therefore I'm going to summarize it in one slide only. So my apologies to some for that, but I'm just going to go through with some key points here. So we know that hypertension prevalence increases massively as the GFR goes down. So that's fact. We know also that hypertension increases the cardiovascular risk in these patients, just like it does in the general population, and that if you treat it, you reduce the cardiovascular risk, and you can slow the progression of kidney disease in diabetics, although it's not quite so clear as to whether you slow the progression in non-diabetics as it happens, which is a slightly intriguing difference. If you treat the blood pressure really aggressively, and by that I mean getting the target systolic down to 120 or less, which is really quite a high bar to be setting in these patients, you can further reduce the risk of cardiovascular outcomes and also of dementia and mortality by being really aggressive in your blood pressure treatment. But you don't actually slow the progression of CKD, at least in non-diabetics. You do in diabetics, but not in non-diabetics. So a slightly mixed picture, but bottom line, high blood pressure is very common, it's very bad, and by treating it, you can do a lot of good to these people. So that's a very simple concept. Now, new kids on the block, SGLT2 inhibitors. Now, for those of you that may not be familiar with this, SGLT2 is a transporter in the kidney. And you may think, eyes may glaze here and say, oh God, he's going to get into renal physiology. Well, don't worry, I'm not. But this transporter is the one that stops you peeing out glucose all the time. It's the tubular transporter that reabsorbs glucose from the renal tubule, such that in health we have virtually no sugar in the urine, unless we have a very high blood sugar. So that's the normal scenario. If you inhibit that transporter, you start spilling glucose into the urine. Now, for a type 2 diabetic, if you think about it, an overweight type 2 diabetic, that might be quite a good thing. It might reduce the glucose burden a bit. You'll start peeing out calories, and most of these people are overweight, so that's potentially a good thing. And so these drugs made sense when they were first being developed as a treatment for type 2. So that would potentially be a good thing. Insulin-independent action, so no risk of hypoglycemia expected. So lose weight, and the sugar in the urine will give you an osmotic diuresis, which may also reduce blood pressure a bit too. So that's quite good. So these drugs looking very encouraging from the profile of their activities. Big clinical trials done. The regulatory authorities have burnt their fingers badly with the glitazone drugs for diabetes a few years before, which had some unexpected nasty sting in the tail. So they were very determined to mandate big studies with a very robust safety component built into them to be sure there's nothing adverse going on. And indeed, there were some unexpected signals that came out of these studies, but they were not dangers, they were positives. So here are 4 of these studies using different SGLT2 inhibitors in type 2 diabetics, and they all had roughly the same effects. MACE is the multiple adverse cardiovascular event, combination cardiovascular death and heart failure, hospitalization for heart failure. And you can see that all the drugs were very good at reducing heart failure. They're working in the same way, so not surprising. Look at these relative risk reductions. So they're reducing relative risk by a lot, 30%-ish, which is big. That's very, very handy indeed. The EMPA-REG study, using a drug called empagliflozin, looked marginally better than the others. These ones weren't significant, but you can see the general trend here. These things seem to be doing some good in terms of cardiovascular outcomes. Now, if we look at what they do to renal outcomes, again, this was completely unexpected that this would happen. They slow down the progression of renal disease a lot. So again, these 3 studies here, looking at the risk of the composite renal, I'm so sorry, this is cardiovascular again, beg your pardon, getting on to renal on the next one. So the risk of the so I'm getting myself in a knot here. These are the renal outcomes from the studies looking at cardiovascular, studies designed to look at cardiovascular outcomes, but these are the secondary analysis of the renal outcomes. And you can see that empagliflozin, canagliflozin, dapagliflozin all substantially reduce the risk hazard ratio is 0.5, 0.6, 0.5 again. These are huge reductions in the risk of progression of renal disease. The meta-analysis on those studies again shows that whichever aspect of renal disease you look at, in terms of outcomes, they're all benefiting substantially from the SGLT2 inhibitor. So this is extremely encouraging. These data are at least as good as we saw with ACE inhibitors and angiotensin receptor blockers in the early days. So this is a really exciting development. A study to look specifically at non-diabetics versus diabetics. Remember, these drugs were introduced for diabetics, so the question is, would they work in non-diabetics as well? And the answer is yes, just the same. So here's a study using this drug, dapagliflozin. These are diabetics, non-diabetics, virtually identical relationship here. Big reduction again in the patients on treatment. So this is really quite startling. I'm going to move through that one rather quickly onto the concluding comments here. So we've got these treatments that really work quite well now, much better than 20 years ago. And there's no doubt that if you're a diabetologist, you have the happy scenario of many more patients with relative stability or only declining very slowly. And the same is true to a lesser extent in the CKD clinics that we do. So things are definitely a lot better. But there are still big dangers around. And it's best to avoid, therefore, any form of CKD. So what are we going to do? We need to minimize obvious things like nephrotoxic exposure, so watch out for the X-ray contrast, watch out for anti-inflammatory drugs, etc. Avoid episodes of acute kidney damage, kidney injury. So this would be hypovolemia, sepsis, things like that. Get in, identify and treat early, and they'll minimize the renal hit. And then retard progression as best you can, ACE inhibitors and SGLT2 inhibitors, as I've explained. The combination these are additive effects, so these patients should, unless there's a contraindication, be on both. Better still if you can cure the thing. Now, you may be able to do that. If you've got a nephropathy that is responsive to treatment, you may cure it. Now, the best example of all is a urological one, obstruction, for example. Acute obstruction will knock kidney function down. If you can relieve the obstruction, you can save the day and get back to near normality after that. So excluding or not missing opportunities to treat underlying kidney disturbances is critically important. Some of the primary glomerulopathies are very responsive to treatment as well. So there are various options here which we've got to be careful not to miss. If you can't do that, get a kidney transplant quick, because kidney transplantation transforms the scenario from one of general misery on dialysis, hard work, life is compromised, life is short, to one of much better rehabilitation, better quality of life, longer life, and from the point of view of the government, much, much cheaper life as well. So transplantation is a cheap treatment compared to dialysis. So everybody's happy if we can do transplants. But we can't do as many as we'd like to, of course, because of the restriction on organs for transplantation. Now, how big is the benefit for transplantation? Huge is the answer. And I'm just going to show you the trajectory of transplant patients in terms of risk of death compared with matched dialysis patients. So here we are. Here's the matched dialysis patient acting as the reference line. When you have a transplant, it's clearly risky to have a big operation. It's risky having all those high doses of those immunosuppressive drugs to start with. But that risk diminishes rapidly, and after about 6 months, you're back to where you started, if you've stayed on dialysis, and after that, it's all plus. And the risk is reduced. So you get back to your baseline risk within 6 months or so, and you recoup what you've lost here by about a year and 3 quarters, something like that. So from this point on, it's all positive. So all this area here is gain from transplantation in terms of survivability. And I say, better quality of life, much cheaper as well. So this is where we want to be. Being there, as I say, is not as easy as one would like it to be because of the shortage of kidneys. A big source of kidneys increasingly is living donors. And I would just urge you, therefore, to take note of this, which was given to me by a trainee of mine many years ago, Charles Newstead, who ended up running the renal program in Leeds, with a nice dark sense of humour about this sort of thing. And if you just glance at that, you'll see what I'm saying. And the message there is, be nice to your family. You never know when they might come in handy. Thank you very much.
John, why don't you sit there, and then I'll just make it easy here just to see. Any questions from the audience? I've got some on my... yes, Professor Oliver, one of our regular attenders of these meetings. Tim Oliver.
Yeah.
Thanks. Tim, just hang on for the microphone, otherwise the people online won't be able to hear.
I know nothing about renal disease apart from what you taught me, but it was a brilliant lecture and I learned a hell of a lot more. But I just wanted, leaving out inflammation, which I'm obsessed by in cancer, whether you are missing a trick or two, or rather, there may not be chronic antigen deposition due to a sort of antibody antigen complexes, possibly from viral, possibly from even chronic anaerobic bacterial disease. But in other words, how much has there been looking at the cause, if you like, and whether there's chronic...
The answer is a lot. The effort that's gone in, the money spent in that broad area that you just defined is huge.
And it's zero.
The beneficial outcome is significant, but probably disproportionately low in relation to the effort that's gone into it, I have to admit. As you correctly say, antigens of various kinds seem to be able to trigger immune complex disease, which is very often targets the kidney. So cancers, I don't need to tell you about that, frequently do that. Chronic infections, malaria, for example, other chronic infections, also various viruses, hepatitis viruses. So that's 3 big areas that can trigger this sort of thing. Others are triggered by unrecognized triggers that we don't spot. But you're absolutely right. And the same can arise in a transplant, of course. It's one of the causes of transplant kidneys failing.
Tim, pass the microphone to Humphrey there, our dean in the second row. And whilst he's getting that, John, I know you've just come back from the Mayo Clinic where they screen everything and everybody if they possibly can. So if a member of the audience were to go to the Mayo Clinic and be screened for everything, what would they be looking for in terms of picking up early kidney disease? Obviously, diabetes and hypertension.
They wouldn't be looking for anything that we don't look for. Essentially the approach is similar. The Mayo Clinic screening for what they call their Executive International Program is quite interesting. Slightly to my surprise, it didn't revolve entirely around doing fancy tests, by any means. And the center point, really, well, the beginning and the end, is seeing a good physician who will start the ball rolling with a proper, decent consultation on our the full Monty, really, proper history, proper examination.
The Queen's physicians.
And then we'll bookend it by when you've had the various tests done and seen a few specialists along the way, if that appears to be necessary, then at the end of it all, which may be a day later, 2 days later, we'll essentially wrap it all up with another 1 hour consultation to sign it off and then produce a big report. So I think the thing they do very well is they do match the investigations pretty well to the patient's needs.
So then don't do everything to everybody.
Nothing like that. No, I think they're smart. They're smart over there. Just as a side, has been a tendency in this country to think that American physicians are a bit over the top, over-investigate, very well informed, but actually not necessarily super duper around the bed. I think this is completely fallacious from my experience of working in America. I think they're jolly good. They're no better than we are, but they are, the best over there is terrific, as it is here. The worst over there is dire, as it is here. No surprises.
And there is actually a Mayo Clinic in London now, as well as the Cleveland Clinic. Humphrey, you've got the microphone there. So
thank you very much.
Dean and a colorectal surgeon.
Thanks. A lovely talk. Thank you very much. You pointed out the advantages of transplantation over dialysis. Mm-hmm. Can you tell me where you think we're going with transplantation? Where we are going with transplantation?
Well, I think the availability of donors, first of all, is a socio-political thing as well as a medical thing. And some countries are much, much better at that than we are, of donor organs, particularly when ensuring that opportunities to use organs from cadavers are not missed. And we were terrible at that for years and years, for all sorts of reasons. Lack of capacity in ITUs, all sorts of stuff. We're a lot better now than we used to be, but we still are not nearly as good as the best. Countries like Austria and Spain, for example, are streets ahead of us on that. So the other source is living donors. We have done well there. We've increased the percentage of living donors as a percentage of the whole a lot in this country. That's almost entirely due to advances in surgical techniques, in my view. So laparoscopic surgery has completely transformed that game, and the reaction of a potential donor patient when you talk to them, and you mention the words keyhole, you can just see it's like an injection of Valium. They relax. They think they're going to have a huge operation. You say, this is going to be a semi-keyhole thing. It's probably going to be done by a robot. Really? Oh, I think I might have that. It just changes the perception dramatically. So that's been a game changer. The other big thing, of course, is making sure that when the kidney gets in, it stays there. It doesn't fail. And again, things have moved forward a lot over the last, during my period in nephrology, with medications, new drugs, and much better use of the drugs that are there as well. So I think the scenario is enormously better than it used to be. But I think the biggest thing of all is still lack of organs. And you asked me about xeno, transplantation, things like that, which has been inching forward in stops and starts for not years, but decades. The early enthusiasm has been tempered by the realization that really it's very difficult to develop a xenograft that is modified sufficiently not to be rejected with extreme vigor. And that's the issue here, is keeping these things in while not killing the patient with massive immune suppression at the same time. So there's always a balance that we're trying to strike there with transplantation, obviously. We're not there yet, definitely.
Nick, I know you've got a question, but I've got 12 online here, and this is a cardiological one, so then I'll come to you, Nick. So John Rudd, Dr. Rudd, thank you for the question. Would Sir John agree that many drugs used in cardiology can be nephrotoxic? Is less often better than more? Is it better to keep such drugs, ramipril, bisoprolol, etc., in lower doses? Nick's shaking his head, but what do you think?
I'm not sure I agree with that. I mean, for a start, I would take exception to the idea that ACE inhibitors and ARBs are nephrotoxic. They're not nephrotoxic as such. What they can do is disturb renal function in a way that is almost always related to the underlying pathology or pathophysiology and reverses when you stop the drug. So they don't damage kidneys like an anti-inflammatory does, for example. The things that cardiologists are most likely to use that damage kidneys are actually is X-ray contrast medium. I would say that's number one by quite a way. Now, in terms of doses of things like beta blockers, ACE inhibitors, ARBs, I think any adverse effect of a high dose, and I'm not aware that there are many, frankly, is more than offset if that high dose achieves a good blood pressure. I think that trumps almost everything else here. So,
just talk a little bit about anti-inflammatories, because so many people take those for their joint problems.
Well, they do.
Are they wrecking their kidneys?
Well, a few of them are. I mean, obviously the percentage of people with normal kidneys who get damage from anti-inflammatories has to be very low, because these are taken like Smarties up and down the land. You buy them at the counter, etc. There's not a lot to choose between the different anti-inflammatories. I might make that point. The so-called these COX-2 inhibitors, that don't upset the stomach nearly as much, they're just as bad for the kidneys. So there's no difference there at all. The vulnerable patients, the high-risk patients for anti-inflammatories, are those who already lost a bit of kidney function. That massively increases the chance of losing more. So assuming you've got normal kidney function, Roger, if you took an anti-inflammatory, the risk is minute. But if you had a GFR of 30, the risk is much, much higher.
And would that just be like a short course, or
the longer,
chronic?
The shorter, the better. But I mean, occasionally you see people who have knocked off the perch with a very, very limited exposure. Yeah.
Nick, over to you.
So I'd definitely agree that we should continue ACE inhibitors and beta blockade. I mean, there's a drug that helps us both, SLGT2 inhibitors. What's your take on that? I mean, I use that in heart failure. Seems to be...
Sorry, I didn't catch that.
SLGT2, dapagliflozin.
Yes, SGLT2, yeah.
Fantastic drugs for the kidney and the heart. What's your take on why that works so well?
Yeah, well, they're diuretics for a start. And you could, if you were cynical at the beginning of this story, which I was a bit actually, say, well, it's no more than a diuretic. If you give an equivalent dose, a tiny dose of furosemide or something, that would also reduce the likelihood of heart failure, which it would. But it does not prolong survival like these drugs do. And they do a lot more than diuretics. Now, one of the things that diuretics do, as you know, is to upregulate the renin-angiotensin system a lot as a countermeasure. That's the body's countermeasure to losing too much salt and water. And that means more angiotensin flying around, which is not thought to be good for the heart or the vasculature, for a start. Now, renin and angiotensin activity of that system actually drops when you're on SGLT2 inhibitor. So that's one possible difference. It's doing a whole load of things in the kidney, particularly, to reduce renal oxygen requirement and change renal energetics. It's not doing much directly in the heart because, of course, there's no SGLT2 receptors in the heart to speak of. There are SGLT1 receptors in the heart. I'm telling you stuff you probably know. One of the new SGLT2 inhibitors, sotagliflozin, inhibits SGLT1 as well. And a big interest is going to be, does that have a greater or lesser effect on the heart as a result? I think the jury's out there.
John, there's one question from Oliver Pfeiffer. Thank you, Oliver. What's the correlation between serum calcium levels in chronic kidney disease, either from secondary or tertiary hyperparathyroidism, and the risk of vascular calcification? Even if you control the calcium levels in CKD, are they still at significantly increased risk?
Yeah.
Vascular calcification.
Thank you. Yeah, they definitely are. So with perfect calcium and phosphate control, which is by no means always achievable in these patients, but if you get it dead right, the risk of vascular calcification is still very substantially increased. It's even worse if your calcium and phosphate are all over the place. High calcium in kidney patients occurs in two scenarios. One is when the parathyroid glands become autonomous and massively overactive, and the other is if someone like me gives them too much vitamin D. or too much calcium and drives the calcium up. But even if you get that spot on, you still have an increased problem with vascular disease, medial vascular disease, and mortality, but less.
So Georgia Perry says, on a bit of a side note, how do you determine the difference between kidney disease or elevated creatinine levels due to frequent exercise and higher muscle mass?
Yeah, very good question. So the definitions developed for CKD have been built around creatinine-based measurements of glomerular filtration rate. And the serum creatinine itself, of course, is our starting point. And the eGFR, estimated GFR, is an estimate. It's not a measurement. It's worth bearing that in mind. And it's a derived value from the serum creatinine concentration. So you then have to ask yourself, well, how reliable is the serum creatinine concentration? Well, the measurement of creatinine, in the technical sense, is very reliable. This is a well-established assay. The quality control in nearly everywhere is extremely good, so you can rely on that. So what determines the serum creatinine level in anyone? Answer, how good the kidneys are at getting rid of it, and how much is coming into the system. And the amount coming into the system is determined by muscle mass. So I get referred significant numbers of patients who are muscle-bound bodybuilders, or even people who just take a lot of exercise, who go to the gym a lot. Many of these have a slightly raised serum creatinine concentration, and therefore a low GFR, eGFR, when it comes to their genuine GFR is normal. They haven't got kidney disease. It's just that the estimated GFR, which is estimated from the creatinine, is artifactually low. So these people sometimes acquire a label as CKD. And if you looked at the, let's say, Olympic weightlifters, for example, they will all appear to have quite severe kidney disease, those people, because they've got ridiculous amounts of muscle on board. The other thing, artifact, is people that take supplements, creatine supplements. That does mess up the creatinine assay, but that's less common and is easily gone around. So what's the solution to this? You have to measure the GFR by some creatinine-independent means in somebody who you think is a bit of an outlier on muscle mass. And the easiest way to do that is to measure stuff called cystatin C, which is a small molecule produced in the liver. Therefore independent of muscle mass, and there are a series of equations which are all readily available and on apps and things to calculate a different eGFR from cystatin C, and most labs will offer that now as well. So that will be the way around it.
I'm going to have one last question online. Peter Njoku says, what proportion of patients requiring a kidney transplant in the UK get it in the optimal time?
Well, not enough, well under 50%.
Is that because of less car accidents and?
Yeah, well, it's partly available. It's partly not enough people are dying, violent deaths. So the nephrologists, crash helmets and things. We see with them mixed views on that. But seriously, there's a finite limit, obviously, on the theoretical number that could become available from deaths. The second thing is that the procurement, the percentage of suitable ones procured, is way short of what it could be and ideally would be. So you've got those two barriers there. Ideal time to transplant is before you start dialysis. You really, if you can, you want to get your kidney in the year before you would need to start dialysis if you're sliding down. That's called preemptive transplantation. The results are better. You sidestep the cardiovascular attrition that comes from dialysis treatment. And if you're a dialysis patient for a few years and then you get a transplant, you still carry a legacy of that dialysis with you, which is not good.
Right, good, all good answers. Well, with impeccable timing, we're near 7:30, so we're on time for that. But it occurs to me that in the week of the Queen's Jubilee, to have the Queen's Doctor here, that makes a lot of sense, doesn't it? So I'm going to hand over to Ted Gordon-Smith now to do the vote of thanks. Ted's an old friend and old colleague of mine from the Thank you, Ted.
And I hope an old friend of Sir John. President, colleagues, I'm very pleased and honoured, of course, but particularly pleased to have this opportunity of saying thank you to Sir John on behalf of the RSM and the audience here and the audience online for a superb addition to the Jephcott Lectures. You need not have been worried about that. It fits in very well with the ones that have gone before. Terrific. These lectures, of course, were set up by the Jephcott Trust, which was a legacy of Sir Harry Jephcott, who was an astonishing man who he was a train driver's son. Of course, sons matter very much in these circumstances, to founding Glaxo and becoming a multimillionaire. And he did it through his love of education. He had many degrees, studied many courses and so on, and eventually left all this money for the Jephcott Lectures, which are specifically for education and health, amongst others. And you've illustrated both those aspects of the Jephcott Trust so extraordinarily well. Your discussion of the links between chronic kidney disease and cardiovascular disease started, of course, with a patient, Jomo, and his problems, which led into the discussion of the research and the problems that are associated with chronic kidney disease. And I think you've illustrated, and your career has illustrated very well, the importance of, or the essential fundamentals of clinical research. Is it starts with the patient and the problems that are associated with the patients, goes to the clinical science, in your case, many, I was going to say decades, but let's say years of research into calcium and its control and parathyroidism, and then back to the patient. How do you manage things? And particularly, are there drugs that can interfere, manipulate the systems which have led to the problems you so admirably outlined in the chronic kidney disease patient? I was particularly pleased that you talked about silos for a moment, because I think we in the medical profession are deeply at fault for creating silos. And I know that the Mayo Clinic deliberately avoids that. By the first person you see when you go there is, as you've told us, a general physician or a physician who examines everything before you're sent to the specialist. And the specialist, instead of just examining your heart, now knows he should look at the kidneys or vice versa. And I think this is a frightfully important aspect of the talk that you've done. And your talk shows that you yourself have had this very distinguished and directed research towards the problems associated with chronic disease. And of course, on the other side, the honour you received in 2014 shows that at least one of your patients appreciated your clinical skills and your bedside manner, but I suspect all of them were pleased to have such an astonishing scientist looking after them as well. But I have a special reason, actually, for being grateful for this moment, being able to say thank you, because I'm going to say thank you to two Cunninghams, of course. My first degree when I went into medicine was in physiology in Oxford, and I was introduced to physiology of respiratory disease by a very delightful and enthusiastic Don called Dan Cunningham. And Dan introduced me not just to things, but he showed me various aspects of respiratory physiology, one of which was to show me what happens when you breathe air from which most of the oxygen has been removed and replaced with carbon dioxide. It was quite an interesting moment and certainly very exciting, and I hope it was done by accident. I have to say the other thing that he kindly introduced me to, and his colleagues, was the oxygen dissociation curve, and I can see all of your eyes crossing at the thought of the oxygen dissociation curve, but it is a wonderful and beautiful example of physiology and biochemistry, of course, leading on to such important clinical aspects. I'm therefore particularly grateful to Sir John for continuing my education in the physiology, in this case, of the kidney and the heart, and also demonstrating this fantastic crosstalk between aspects of cardiac disease and kidney disease which are not apparent to the ordinary chap who sees atherosclerosis plaques and kidney disease and so on, but this gradual thickening of the wall at a cellular level with the deposition of calcium. And of course, techniques these days are such that you can examine intracellularly exactly what is happening there. Now, I believe, Roger, that I have to present something before I say my final thanks to Sir John. Oh, we've got to take it up. Anyway, at this stage, Sir John, a personal thanks to you and the family for all these things that have done.
Right. There's the medal in there, so if you get the medal out.
Well, no, you get the medal out. Oh, no, I'll take the lid off. You can look in the medal. Hey.
There's another lid.
Yeah, it's a little box of chocolates, actually.
Oh, is it?
Let's have a look. There you go.
5 layers.
Three professors tried to
Oh, there you are. So you hold that.
Thank you very much.
Very good.
Okay, and you hold that.
I hold that. Right
Okay,
there.
and I take the photograph.
There you go.
We should really have a picture, shouldn't we?
Well done.
And then you have the big beaming smiles, please. There we go. Maybe just move slightly to your right. There we go. Perfect.
Okay.
I think a round of applause.